Hey there, this is video number 4. We are describing sulfonamides and cotrimoxazole. Sulfonamides is the first topic we are going to describe. These are all considered as derivatives of sulfanilamide or para-aminobenzene sulfonamide. This is how the chemical structure would look, and it was discovered by Domag. He was doing experimental streptococcal infections in mice, and he found that prontosil red, one of the dyes he was using, was amazing in treating these streptococcal infections. They are highly effective. Then it is said that an infant was suffering from staphylococcal septicemia, which was 100% fatal at that point of time, and Domag took the risk of giving prontosil red to that baby, and surprisingly, it was, the child, the infant was saved. So this is the story behind how this thing was discovered. And prontosil, later on they realized that prontosil by itself is not really an antimicrobial. It was degraded in the body to release a compound called as sulfanilamide, which is an antibacterial agent. And then you of course had a large number of sulfonamides that were made. Actually, they were not just made, they were abused to a level where most of the bacteria now are practically resistant to sulfonamides. We have a less number of sulfonamides available today, which actually do a pretty good job. Okay, and these sulfonamides are as follows. We classify them as short acting, intermediate acting, long acting, and special purpose sulfonamides. Short acting are sulfadiazine, intermediate acting are sulfamethoxazole, long acting is sulfadoxin and sulfamethopyrazine. Special purposes is sulfacetamide, sodium, mafenide, silver sulfadiazine, and sulfasalazine. Now, the problem with these medications is the abuse that we have done. They have been abused to such a level that practically all sulfonamides are now useless. But how do they work? That's the real question that we need to answer here. Now, sulfonamides actually are active against those bacteria that make their own folate. Now, this is how they make their own folate. Okay, the bacteria actually use PABA, that's para-aminobenzoic acid, and they combine it with something called as pteridine. Okay, and that combination of PABA plus pteridine gives the bacteria dihydroteroic acid, which is then converted with the addition of glutamate into dihydrofolic acid. And this dihydrofolic acid is really not the useful stuff. It is converted into tetrahydrofolic acid by enzyme dihydrofolate reductase. Sulfonamides are structural analogues of PABA. Okay, they look like PABA, and that's how they inhibit the very first step of folate synthesis in bacteria. This enzyme is the folate synthase. So by blocking folate synthase enzyme, the folic acid is not formed, and folic acid is important for many essential metabolic reaction. Sulfonamides competitively inhibit the union of PABA with pteridine residue. Dihydroteroic acid is not formed. So if dihydroteroic acid is not there, glutamic acid cannot combine with it, it cannot produce dihydrofolate, so no tetrahydrofolate. Okay, actually, because sulfonamides look like PABA, they might get incorporated or added on to this pteridine and give you altered folate, which is metabolically very injurious. Okay, now you might be wondering, we also require folate, why are we not getting affected by it? Actually, PABA and this combination of PABA with pteridine residue, this happens only in bacteria. We eat folate. We actually start our folate metabolism directly at this step. We eat this in our diet, and this conversion takes place in our body. Since we are not blocking this step, this part only happens in bacteria, and hence only bacteria are getting affected. Easy, simple to understand. Now, why do you think this is only the mechanism of action? Well, there are proofs. If you add PABA, it will antagonize the action of sulfonamide. So there is a competition between PABA and sulfonamide. That has been proven. Secondly, only those microorganisms that synthesize their own folate, which cannot take it from the medium, actually die because of sulfonamides. Otherwise, they will pick up from the diet, right? So they will also start at dihydrofolate level. Now this is important. The pus and tissue extracts, they contain purines and thymidine. These purines and thymidine decrease the bacterial requirement for folic acid, and hence in pus, sulfonamides will not work. The purines and the thymidine antagonize sulfonamide action. Even pus is rich in PABA. That's the reason why it does not work that good. Okay. So what else do we need to know? Well, there are some side effects. Now before I go to the side effects, let me also quickly tell you that the bacteria can become mutant either by making more PABA or changing their folate synthase enzyme to become a low affinity enzyme for sulfonamides, or use alternate pathway for metabolism. And once the pathway changes, or they can make their own more PABA, or they can change their folate synthase enzyme, then they practically become resistant to all sulfonamides. That's the big problem. Now as far as the sulfonamide side effect is concerned, you will remember SSSS. That is the best way to remember side effects of sulfonamides. It is simple. First S stands for Steven-Johnson syndrome. That's when the skin peels off. More than 30%, 25% skin peeling off at the same time is called as Steven-Johnson syndrome. If less than 5%, 10% peels off, we call it exfoliative dermatitis or skin rash. S, solubility decreases. So what is the solubility decreases? Solubility of various ions in the urine decreases. So stones start forming in the urinary tract. So that can cause crystalluria, that's crystals in the urine. And lastly, it displaces serum bilirubin. Now the serum bilirubin we are talking about is the unconjugated bilirubin. In you and me, because we are grown-ups and we have very good blood-brain barrier, probably this displacement does not matter to us, because nothing really will happen to us. We have a very good blood-brain barrier. This unconjugated bilirubin cannot enter into our brain. Simple. Now, important. In a newborn baby, the blood-brain barrier is not formed properly, and as a result, this extra unconjugated bilirubin can enter into the brain and cause serious damage to the brain of the baby, causing something called as kernicterus. Simple. Apart from this, there are other side effects such as nausea, vomiting, epigastric pain, neutropenia can happen, that's neutrophil counts decreasing, hepatitis can happen, and hemolysis can happen in patients who are having glucose 6-phosphate dehydrogenase deficiency, because this seems to be an oxidative enzyme, an oxidative drug. This is what you need to know as far as sulfonamides are concerned. The chances of them asking you this is pretty low. Let me also help you out a very quick look at the antibacterial spectrum. They are bacteriostatic. They stop the division of gram-positive and gram-negative bacteria both, but at higher concentration, especially in urine, they can be cidal also, they can kill also. So Streptococcus pyogenes, H. influenzae, Haemophilus ducreyi, Calamantobacterium granulomatis, Vibrio cholerae, they respond. Okay, anaerobes don't. Chlamydia is still sensitive. So these are 3-4 bacteria, 5 bacteria that you can easily remember. Please do that properly. Okay, which brings me to the only real one that we use nowadays, silver sulfadiazine. Sometimes even mafenide is used. It is fantastic for burns treatment. Another use of sulfonamides is giving it in combination with trimethoprim. So when you combine sulfonamides with trimethoprim, you get cotrimoxazole. To be precise, sulfamethoxazole plus trimethoprim is cotrimoxazole. It can be used for pneumocystis jirovecii infection, nocardiosis, even for malaria and all. It has been tried along with pyrimethamine, sulfonamides, toxoplasma. So rarely any uses are available now. So just have a look at it. Don't forget to add ocular sulfacetamide sodium, cheap alternative in trachoma inclusion conjunctivitis. Okay, I hope you have done chlamydia chapter from microbiome. This should really help you there. Let's now start with cotrimoxazole. Very important. This is actually a fixed dose combination of trimethoprim and sulfamethoxazole. The trimethoprim part is basically diaminopyridine or pyrimidine. It is just like pyrimethamine, and it inhibits that enzyme called as dihydrofolate reductase. So this is a selective inhibitor of bacterial dihydrofolate reductase. Now, where is that enzyme present in this case? You already know the fact that pteridine plus PABA combine to form dihydroteroic acid. That's folate synthase enzyme. Dihydroteroic acid combines with glutamate to form dihydrofolic acid, and the dihydrofolate is converted into tetrahydrofolate by dihydrofolate reductase, RASE. This is the enzyme we are discussing, dihydrofolate reductase. Trimethoprim blocks this enzyme. So if you notice, in the same sequence, in the same series of reaction, there are two blocks created, first by sulfonamide, second by trimethoprim. This kind of a blockade is called as a sequential block. Now, this is the fun part. Both of them are bacteriostatic. The combination is sidal. Now, if the bacteria is susceptible to both, the combination will become even more deadly. Okay? Now, if you want the best synergy, the best action against microorganisms, then the concentration at the level of microorganism, which means the plasma concentration, should be sulfamethoxazole 20 to trimethoprim 1. Okay? Now, this combination, like 20 times sulfamethoxazole more than trimethoprim, this combination works fantastic and it kills the bacteria the best. Actually, this combination in this ratio, sulfamethoxazole 20 to trimethoprim 1, is so amazing that the minimum inhibitory concentration of each of this component gets reduced by 3 to 6 times, which means we need to give that much lesser drug. Now, if you want this ratio of 20:1 sulfamethoxazole to trimethoprim in the plasma, then you have to give the dose in the ratio 5:1. So when you give 5:1, then the sulfamethoxazole will become 20:1 sulfamethoxazole. So now if you give this medicine at the ratio of 5:1, automatically the concentration in the plasma becomes 20:1. Now why would that happen? Trimethoprim is more lipid soluble. It enters many tissues, so it has larger volume of distribution. Sulfamethoxazole only has like concentration in the plasma only, so it does not go anywhere. Okay. So comparatively speaking, if you give same dose, then it will not work. 5:1 dose, it will become 20:1 in the plasma, and then it will work fantastic. Actually, trimethoprim can even cross the blood-brain barrier and placenta also. Sulfamethoxazole does not. Anyways, what is more important is the fact that this sequential block is amazingly effective. Okay, amazingly effective. The side effects will be more or less similar to sulfonamides that we studied. The adverse effects also are going to be more or less similar to the things that we like, same nausea, vomiting, stomatitis, headache, rashes. The only extra thing is folate deficiency can happen, and megaloblastic anemia is known to happen in some patients, and even blood dyscrasias can happen at rare occasions. Never give it in pregnancy. This is basically an antifolate, so there is a chance of teratogenicity. Near term, it can even cause neonatal hemolysis and methemoglobinemia. So be very careful. Don't give it to patients with renal disease. It might cause uremia, and it has slightly higher frequency of fever, rash, and bone marrow hypoplasia, especially in patients of AIDS who have been treated for pneumocystis jirovecii infection with cotrimoxazole. Even elderly are at a risk for bone marrow depression, so don't. Diuretics plus cotrimoxazole is also a very bad combination. It causes thrombocytopenia. The uses again will be just like the original one, the sulfonamides. Urinary tract infections, actually for uncomplicated infections, for uncomplicated UTIs, this is amazing. 4 tablets of cotrimoxazole for acute cystitis, fantastic. Okay. 3 to 4 days courses have also been advised for lower and upper urinary tract infections. That can be one use. Respiratory tract infection like chronic bronchitis or maxillofacial infections or facial-maxillary infections, otitis media, gram-positive cocci, H. influenza, Moraxella catarrhalis, they respond very nicely. Bacterial diarrheas and dysentery, especially E. coli, Shigella, Salmonella, non-typhoid Salmonella and E. coli, they also work pretty good. Pneumocystis jirovecii, very nice for pneumocystis jirovecii. These many at least you should write. Apart from that, chancroid and typhoid, once upon a time they were used, but now it's not really the case. Easy, simple. This is it for this video. I hope you have understood it. Please go through it. Let me know if there's any doubt. I will be more than happy to help you. The next topic is going to be anti-tubercular drugs. One of the most important chapters. Finish this much, then move on to the next topics. Okay? Till the next time we meet, this is Dr. Avinash signing for now. Take care, keep studying and keep rocking. Bye bye.